Welcome to the Deep Dive, your shortcut to understanding complex topics.
Today we're getting into subclinical hypothyroidism.
Yeah, medical notes can be, well, a lot. So we're boiling it down for you, the key stuff you need to know.
Exactly. We've sifted through the definition, the risks, the causes, how it works, the whole picture, really.
The aim is to give you that solid foundation.
Think of it as us chatting through the notes together, making sense of it all.
Perfect. So let's start right there. What exactly is subclinical hypothyroidism?
Okay, so in simple terms, it's when your blood test shows your TSH, that's thyroid stimulating hormone, is a bit elevated.
Higher than normal range.
Right. But, and this is the key bit, your free thyroxine, the FT4, is still testing within the normal range.
Ah, okay, so one marker's off, the other's okay.
Precisely. And that's why it's often called mild thyroid failure. A lot of people, maybe even most, don't have any symptoms. They feel fine.
So it's kind of lurking in the background?
You could say that, but it's significant because it can progress.
Progress to what?
To overt hypothyroidism, where the FT4 does drop below normal.
Mm-hmm.
The note suggests this happens maybe 2 to 5% of the time each year.
Okay, not a huge percentage, but not nothing.
And that risk is higher if someone also tests positive for thyroid autoantibodies. So it's definitely something to be aware of.
And getting that diagnosis, it's not just based on one single test result, is it?
No, absolutely not. TSH levels can bounce around a bit. Stress, time of day, other factors.
Right.
They can influence it.
Right.
So if you get one high TSH reading, you really need a repeat test to confirm it's persistently elevated.
Makes sense.
And interestingly, the sources mentioned that for people whose TSH is only mildly elevated, say between 4 and 10,
yeah.
something like 62% might actually see their TSH levels return to normal all by themselves within about 5 years.
Wow, really? So it can just resolve?
It seems so in a fair number of cases.
Yeah.
Which is why jumping straight to treatment isn't always the answer.
So TSH is the main screening tool then, because it's sensitive.
It is. It's very sensitive. There's this logarithmic relationship with T4, which means even small dips in your T4 can cause a relatively big jump in TSH.
Like an early warning system.
Kind of, yeah. The pituitary gland is sensing the thyroid isn't quite keeping up and yelling a bit louder, increasing TSH.
And T3, where does that fit in?
Well, the thyroid itself actually produces relatively little T3, which is the more active hormone.
Oh.
Yeah, most T3 is made in the rest of the body, peripherally, by converting T4 into T3.
I see. And you mentioned reference ranges earlier. They aren't set in stone.
No, they're not universal. They can be influenced by things like age, ethnic background, how much iodine is in the local diet. And there's actually an ongoing debate about what the upper limit of that normal TSH range should even be. Factors like underlying autoimmune thyroid disease in the reference population can skew things.
Fascinating. Okay, so that's the what. So let's move to the why. What causes subclinical hypothyroidism?
The big one, responsible for like 90% of cases, according to these notes, is autoimmune thyroid disease.
Hashimoto's.
Exactly. Hashimoto's thyroiditis.
Mm-hmm.
That's where your own immune system attacks your thyroid gland.
Right. You had a mnemonic for that.
Ah, yes. I think Hashimoto's is like saying, harming my thyroid, helps it stick.
Ah, I like that. Okay, so Hashimoto's is number one. What else?
Well, sometimes the thyroid gland itself might just not be functioning quite right for other reasons. Certain medications can interfere.
Like which ones?
Lithium and amiodarone are classic examples mentioned. Iodine deficiency can cause it, though that's less common now in places like the UK.
Okay.
Also, if someone's had treatment for an overactive thyroid, like radioactive iodine therapy, that can sometimes lead to underactivity later on.
Makes sense.
Any others?
Yeah, previous surgery on the head or neck or radiotherapy to that area can also potentially damage the thyroid.
Got it. So moving on, who's more likely to get this? What are the risk factors?
Several things pop up consistently. Getting older is a big one. Advancing age increases risk.
Okay.
It's also definitely more common in women than in men.
Having a family history of thyroid problems is another key risk factor. And if you personally have other autoimmune conditions like type 1 diabetes or rheumatoid arthritis, your risk is higher too.
And the medications we mentioned.
Yes, and those specific treatments affecting the thyroid, like the radiation or surgery.
Okay, let's peek under the hood a bit. The pathophysiology. What's actually happening biologically?
So even though that FT4 level is technically normal, the raised TSH is the body signaling that the thyroid isn't quite meeting demand.
The pituitary is working overtime to stimulate it.
Exactly. It senses a slight dip in thyroid hormone output, or perhaps efficiency, and ramps up TSH production to compensate.
And the thyroid is just barely keeping up enough to maintain normal FT4.
That's the idea in subclinical hypothyroidism. The underlying issue is usually some degree of impaired thyroid hormone synthesis or secretion, caused by whatever the root cause is, often that autoimmune destruction from Hashimoto's, or maybe one of the other factors like medication side effects or post-treatment changes. The mechanism is similar to overt hypothyroidism, just less severe at this stage.
Right, okay. Now, it's important not to jump to conclusions with just a lab result. What else could mimic this picture? The differential diagnosis.
Good point. You definitely need to rule out other things. The most obvious is, well, actual primary hypothyroidism, where both TSH is high and FT4 is low.
Okay, distinct from subclinical.
Yes. Then there's central hypothyroidism. That's different because the problem isn't the thyroid itself, it's higher up. The pituitary or hypothalamus isn't signaling properly, so TSH might be inappropriately normal or even low despite low FT4.
A different pattern entirely.
Completely. Also, sometimes medications can mess with TSH secretion directly, not just thyroid function. Recovering from a significant non-thyroidal illness can temporarily cause TSH fluctuations too.
So someone's TSH might spike while they're getting better from pneumonia, for example.
Potentially, yes. And you always have to consider lab errors, assay variability, or sometimes substances in the patient's blood called heterophile antibodies can interfere with the TSH test itself, giving a falsely high reading.
Lots to consider. Anything else linked, maybe indirectly?
The notes do mention an association between subclinical hypothyroidism and some cardiovascular risk factors, things like slightly higher triglycerides, total cholesterol, and LDL cholesterol.
You have bad cholesterol.
Right. But it's generally stressed that these changes are milder than what you typically see in someone with overt hypothyroidism.
Okay, let's zoom out. How common is this condition in the UK? What's the epidemiology?
It's actually pretty common, particularly in older adults and, as we said, more so in women.
Any numbers?
The estimates mentioned are around 8% of women and maybe 3% of men in the UK might have it.
8% of women? That's quite significant.
It is. And the prevalence definitely climbs with age. The risk is noted as being higher in people over 55.
And are more people being treated for it now?
That's an interesting trend the notes point out, yeah. Treatment with thyroid hormones, particularly levothyroxine, seems to be increasing, especially among older individuals.
Now, the clinical picture, what does it look like? We know it's often symptomless.
Exactly. That's the main headline. Often no specific signs or symptoms at all.
But if someone does have symptoms, what might they be?
They tend to be quite subtle and non-specific. Things like maybe feeling more tired than usual, perhaps some slight weight gain, skin might feel a bit dry, or maybe some mild cognitive fuzziness, like trouble concentrating.
Very vague stuff. Could be anything, really.
Precisely. That's the challenge. It can be helpful, though, to contrast that with the clearer symptoms of overt hypothyroidism.
Just for context.
Yeah. Things like significant depression, real fatigue, high cholesterol showing up on tests, feeling properly cold when others aren't, constipation, noticeable weight gain that's hard to explain, a hoarse voice, even changes in hearing or menstrual cycles in women, slow reflexes. Those are much less likely with just subclinical hypothyroidism.
Okay, that distinction is helpful. So how do we actually nail the diagnosis? Investigations.
It boils down to blood tests. Measuring TSH and FT4 levels is key. That's the core diagnostic step.
And the antibody tests.
Doctors often order thyroid antibody tests as well, particularly anti-TPO antibodies, to see if there's evidence of that autoimmune process, Hashimoto's.
Is everyone screened for this in the UK?
No. Routine screening of the general population isn't recommended by UK guidelines.
So who does get tested?
Testing might be considered, for example, in women around the time of menopause, or in older people who present with those kind of vague, non-specific symptoms we talked about, fatigue, cognitive changes, etc.
And if the first test is borderline?
Then repeat testing is really important, especially if the person has no symptoms. Consistency is good too, trying to get the repeat test done around the same time of day, maybe fasting, though the fasting part is less critical for thyroid tests than for, say, lipids.
Right. Okay, diagnosis confirmed. How do we manage it in the UK? What's the approach?
It really varies. It's not a one-size-fits-all situation. It depends heavily on the patient's age, whether they actually have symptoms, how high that TSH level is, and if we know the underlying cause.
Are there specific guidelines, like from NICE?
Yes, NICE, the National Institute for Health and Care Excellence, has guidance. Let's break it down a bit.
Okay.
For someone under 65 with a TSH between 4 and 10, so mildly elevated, and normal FT4, If they also have symptoms that could plausibly be from hypothyroidism,
Like that fatigue or dry skin.
exactly, then a trial of levothyroxine treatment might be considered.
A trial, meaning not necessarily forever.
Correct. The idea is you try it for maybe 6 months, see if the symptoms improve. If they don't, then the guidelines suggest stopping it because the symptoms were likely due to something else.
Interesting. What about older people in that TSH-410 range?
For those aged 80 or over, the general approach recommended is often watch and wait, just monitor.
And if someone has no symptoms at all, TSH-410.
Then the usual approach is observation. Repeat the thyroid function tests in about 6 months and see what's happening.
Okay, that covers the TSH-410 group. What if the TSH is higher, say above 10, but the FT4 is still normal?
Right, higher TSH. For people aged 70 or younger, NICE suggests starting levothyroxine treatment even if they don't have symptoms.
Oh, okay. So above 10 is treated more readily.
Generally, yes, in the under 70s. Again, for those 80 and over with TSH above 10, watch and wait might still be considered, weighing the pros and cons.
So age is a big factor in the decision.
A very big factor. The guidelines also specifically mention considering levothyroxine if someone has a TSH consistently at 10 or above on 2 separate tests, maybe 3 months apart.
Confirms it's not just a blip.
Exactly. And there's that point again about a 6-month trial for adults under 65 whose TSH is above the normal range but still below 10 if they have persistent hypothyroid symptoms.
So levothyroxine is the main medication used.
Yes, synthetic thyroxine or T4, that's the standard treatment.
And the dosing, how is that decided?
Typically, for adults under 65, they might start on 50 micrograms once a day. For older adults, say over 65, or those with heart conditions, a lower starting dose is usual, maybe 12.5 or 25 micrograms daily.
Start low, go slow, especially in older people.
That's the principle. Then you monitor. Blood tests are checked usually every 6 to 8 weeks initially while adjusting the dose.
And one stable.
Then less often, maybe every 6 to 12 months.
What's the target TSH level when someone is on treatment?
The goal is generally to bring the TSH down into the lower part of the normal range, typically aiming for somewhere between 1 and 3 MIUL for most adults.
Are there any major risks with taking levothyroxine?
It's generally very safe when dosed correctly. One thing mentioned is a potential contraindication, or at least caution in severe osteoporosis, as over-replacement could potentially increase fracture risk, although that's more debated.
Okay. So the overall goals are symptom relief, if symptoms were present, and getting that TSH number back into the target range.
That sums it up well.
What about the long-term picture? The prognosis for someone diagnosed with subclinical hypothyroidism?
Generally, it's considered good. Remember that statistic, a lot of people with mildly elevated TSH in that 410 range actually normalize on their own over time.
The 62% within 5 years.
Exactly. But there's still that risk of progression to overt hypothyroidism we talked about.
The 2-5% per year.
Right. And that risk is higher if the starting TSH was over 10, if those thyroid antibodies are positive, and it's also higher in women.
Any other long-term risks associated?
Well, there's some evidence linking a TSH persistently above 10 MIUL with a slightly increased risk of cardiovascular problems like heart disease or heart failure and even cardiovascular mortality.
So another reason to potentially treat those higher TSH levels.
Possibly, yes. The notes give some specific annual progression rates based on TSH and antibody status. It's around 4% risk per year if you have both high TSH and antibodies, maybe 2-4% with just high TSH, and 1-3% with just antibodies.
That gives a clearer idea of the risk levels. Now, a really crucial area of pregnancy. How does this condition impact pregnancy?
This is incredibly important. Early in pregnancy, before about 10-12 weeks, the developing baby is completely dependent on the mother for thyroid hormone.
Okay.
And studies have linked even mild maternal hypothyroidism, including subclinical A, to potential problems like learning difficulties in the child later on, and an increased risk of miscarriage.
That's serious.
It is. Even later in pregnancy, maternal hypothyroidism might increase the chances of needing a C-section or the baby having a low birth weight.
So careful management during pregnancy is vital.
Absolutely critical. Thyroid function needs to be monitored closely, and if the mother is on levothyroxine, the dose almost always needs to be increased during pregnancy, sometimes quite significantly.
Right.
Guidelines often recommend considering screening for thyroid dysfunction in pregnant women who have known risk factors.
Like what?
Like having a goiter that's an enlarged thyroid, having high antibody levels, a family history of thyroid disease, or symptoms that could suggest hypothyroidism.
And the advice if someone has subclinical hypothyroidism and is planning pregnancy.
The strong advice is usually to consult with an endocrinologist before getting pregnant or as soon as pregnancy is confirmed to ensure optimal management from the very start.
Okay, really key points there. Finally, what are the main complications if subclinical hypothyroidism isn't identified or managed appropriately?
The big one is progression to overt hypothyroidism, bringing with it all those more significant symptoms and health risks we discussed earlier.
Like the fatigue, weight gain, cholesterol issues.
Exactly. And then, as we just covered extensively, in pregnant women, unmanaged or undermanaged subclinical hypothyroidism poses real risks for adverse outcomes for both the mother and the baby.
Okay, let's try and wrap this up. What are the absolute key takeaways from this deep dive?
All right, subclinical hypothyroidism. It's defined by that raised TSH, but normal FT4. Often you won't feel any different.
But there's that potential risk of it becoming overt hypothyroidism.
Yes, and it requires special attention during pregnancy due to risks for the baby.
Management in the UK is quite nuanced, isn't it? Depends on age, symptoms, TSH level.
Very much so. It's not automatic treatment for everyone. Watchful waiting is common, especially for milder cases or older individuals without symptoms. Levothyroxine is the treatment if needed, aiming to normalize TSH and relieve symptoms.
And of course, this whole discussion is based on the notes we've reviewed. It gives you a good overview, a solid foundation.
But it's definitely not a substitute for talking to your own doctor or healthcare professional. If any of this raises concerns for you, please seek proper medical advice.
Absolutely. Health decisions need personal consultation.
And if you are studying for exams or just want more revision resources, don't forget to check out passthemsra.com.
And for free resources, there's also freemsra.com.
Great places to continue your learning.
Well, thank you for joining us on this deep dive into subclinical hypothyroidism. We hope it's helped clarify things for you.
Yeah, hope it was useful. We'll catch you on the next one.